So I'd like to go ahead and introduce Dr. Tracy Gertler. I connected with Dr. Gertler through yet another different potassium channelopathy mom who referred me to her because she has great expertise in these channelopathies and is also just a wonderful and kind human and doctor. And Dr. Gertler is going to be presenting, Tristan, she sees Tristan via telehealth, and she'll be presenting on the clinical presentation of KCNH1 related disorders.
Thanks, Michelle. So I'm going to breeze through this a little bit and try to hit the highlights, but I'm happy to answer questions later. Michelle asked me to talk.
Dr. Gertler, I'm sorry to interrupt. We were seeing your presentation, but then you moved it over. I'm not sure if you could move it back. That would be great. Thank you.
How's that?
That's perfect. Thank you.
Okay, thanks. Thanks for interrupting. So I'm going to talk a little bit about the clinical presentation of some of the KCNH1 associated conditions. I know we've already spoken about Temple-Barretzer syndrome and Zimmermann-Leban syndrome and how we've known it by different eponyms, but now that we understand the gene, I think it's most helpful to keep using the gene name, and then we can talk about variability in the phenotype. In several of the early papers that have come out, they have included images of characteristic facial features of these children. So we see elongated faces, and what you'll notice is that there seems to be some weakness or decreased activation of the facial muscles. For the clinicians, that's what we call myopathic face. And that can be helpful as a signal to consider some of the potassium channelopathies like KCNH1. We also see in multiple papers pictures of the hands and feet, and you'll notice shortened digits that are a little bit farther away. So the thumb that is a little bit farther from the other fingers, and then either absent or smaller nails. And these first descriptions were really made when a clinical diagnosis based on facial features, developmental delay, seizures were put together and said, okay, we don't have an answer for why these children have these challenges. What is the gene that we can identify? So this first paper in 2015 noted that 5 kids with Temple-Barretzer syndrome all had variants in the KCNH1 gene that encodes a potassium channel, as you just heard. Subsequent papers looked at kids who didn't have other genes that were known to cause similar features and be associated with Zimmermann-Leban and Temple-Barretzer, but also noted primarily de novo variants that were in the channel. There is some talk about whether these variants cluster in certain parts of the channel. We often see an increased risk of having a genetic syndrome when the most important parts of a channel, like the part where the potassium ions themselves flow through, or the part of the channel that detects a change in voltage, is affected. And I think the jury's still out for KCNH1. So really having more knowledge of more cases as a greater number of families sign on and agree to provide their genetic information and correlate that to what they see in their children is really helpful. And this is the third paper that we have that really looks at these children. And I just wanted to pull up this table to point out some of the common features, because although it is a small population, we're starting to learn more. So as we mentioned, most of the cases are de novo, meaning new in the child, not found in the parents, although now there are several reports where parents have what we call low-level mosaicism, meaning only a very small percentage of their cells have that variant, and they are able to pass it on. It doesn't seem that there's a male or female sex predominance. Most kids do have intellectual disability and seizures, although the severity of the intellectual disability and seizures are variable. We see the coarse facial features, the enlarged gums that we mentioned, and the changes in fingers and nails, and then scoliosis or curvature of the spine is another common feature. this is, as I mentioned before, we're really curious to know, do these variants seem to sit in the same place in the gene or in the protein that's encoded? And this is important because when we think about medications, many medications are targeted towards a specific part of a protein. And when we want to know which one is most effective, we want to know which one is going to change how that protein works in a way that would help most children too. So this is the paper that suggests that many kids with epilepsy have these changes in the gene or the protein in the parts of the protein that bring together the different passes through the membrane. The big point of this slide is that having more variants and seeing where the common variants fall is critical. We know a little bit more about epilepsy in these children as well. So we see generalized, meaning seizures that come from all over the brain, and focal seizures that come from one very small part. And in a large number of kids, we see that the background EEG, or the recording, even when they're not having seizures, is different than what we would expect of other children this age. And so this may be a very helpful biomarker going forward when we're trying to assess, is a medication working? Is a gene therapy working? It doesn't necessarily have to be only a change in seizure number. Sometimes the improvement in those background brain rhythms can be an indication of whether a drug is helpful. And a latest report also points out that some children with KCNH1 variants actually don't have the soft tissue findings or the skeletal findings, meaning the same facial features or the changes in their nails and finger length. And that's important because as we start to test more and more for kids with KCNH1 variants or more broadly, we're going to find more children and the phenotype is going to broaden, meaning not everybody is going to have a textbook case. But still having these families participate in the natural history study is critical because we want to know the full spectrum of what's associated with the gene and why some kids are more or less affected. This is an image that I stole from a different disease foundation talking about mitochondrial variants, but I think it's helpful in that it illustrates we can characterize a syndrome by a phenotype, meaning how children appear, how we diagnose them clinically, and by a genotype. And sometimes those two things happen independently, but then when they come together, that's when we really start to learn what is the disease, what is the disease mechanism, and how can we improve upon it. And I mostly wanted to echo what Dr. Chung said about the importance of a natural history study. So once we get data about as many children as possible, we can better understand what does the disease look like over time? How does it change as children get older? What are the biomarkers that we can use to follow disease progression? And if you look on the bottom graph, clinical trials have traditionally included a placebo group, which means children who are not being actively treated. But if we're able to assemble a robust natural history study where we understand the progression of the disease for most children, then that decreases the need for a placebo, meaning that we can treat more children off the bat. So I'm going to end there, and I'm happy to pass it back to Michelle or take questions.
Tracy, just really quickly, we did have one question about the risk of passing an asymptomatic mosaic parent passing on the gene, the dysfunctional gene.
Yeah, so it's a challenging question because we have limited ways of testing for mosaicism right now. And really, we want to test for mosaicism in eggs or sperm because that would be what's most relevant to the next generation. So there are companies working on that, but it's not something clinically available. The best we can do is test parents and see if they have the gene to the limits of what we can detect and counsel that most likely they will not have another child, but there is a possibility that that variant is present in eggs or sperm and we just can't detect it right now from blood. So if that is a question that is really important. It's also worth talking to a prenatal genetic counselor and finding out about early testing of a fetus, either through CVS or amniocentesis, to see, does the fetus have that variant, or there are some other technologies that can be used in combination with in vitro fertilization as well.
Okay, thank you very much.